shoes.
So you got some slack. No. Sure. I get it.
we all here? Well, good afternoon, and at the outset, let me thank everyone at Elmhurst Hospital Center for hosting us today. As many of you know, this hospital serves one of the most ethically diverse areas in New York, and its emergency department is playing a leading role in our administration's efforts to stop a serious and growing problem all across our city, which I wanted to talk about today, and that is the misuse of prescription painkillers. And that's why we've come here today to announce the city's new emergency room guidelines on prescribing opioid painkillers. Now, voluntary guidelines that have been adopted in all our city's public hospitals, and they're designed to reduce the over-prescription and abuse of these powerful and, if misused, potentially very dangerous drugs. These guidelines, which are summarized on the posters right here on display, were endorsed by the Task Force on Prescription Painkiller Abuse that I appointed just a year ago. Before I describe the guidelines, let me summarize why they're so urgently needed. As a task force report we're also issuing today shows, and I really can't urge you enough to read this because this is the story of tomorrow. Abuse of prescription painkillers in our city has increased alarmingly in recent years. We talk about other problems, we talk about narcotics, but this is one of the things that is growing much more rapidly. Health surveys show that more than 250,000 New Yorkers over the age of 12 report either misusing the opioid painkillers that have been prescribed to them or abusing painkillers that haven't been prescribed to them. Either behavior can have very serious health consequences, and between 2004 and 2010, the last year for which full statistics are available, the number of painkiller-related emergency room visits in our city has increased by 143%. Between 2005 and 2010, unintentional drug overdose deaths involving prescription painkillers has increased by 30%. Addiction to such painkillers also threatens the health and safety of us all. It can and does, for example, lead to criminal behavior that can range from Medicare fraud to holdups at neighborhood pharmacies or other violent crimes. Hospital emergency departments play a critical role in providing pain medication, as you know, and also in dealing with the effects of painkiller abuse. So they're on both sides of the issue. And that's why we urge all New York hospitals to follow the excellent example that Elmhurst Hospital Center is setting by adopting these guidelines and posting them prominently. We want all emergency room patients to understand that these painkillers can be dangerous, that they shouldn't ask for them unnecessarily, and they should only be used when prescribed by a doctor. Now, as you can see from the posters on display here, the guidelines clarify that. Emergency departments will not prescribe long-acting opioid painkillers such as OxyContin. In most cases, they will not prescribe more than a 3-day supply of opioid painkillers, and they will not refill lost, stolen, or destroyed prescriptions. The posters, as you can see, are available in English, Spanish, Chinese, and Russian. The prescription painkillers are legally produced and sold, which makes them easier to obtain than other addictive drugs. That's one of the problems here. However, that also makes it easier for us to track their distribution and usage, which gives us an opportunity to prevent their diversion, resale, or abuse. The city's task force worked with city and federal law enforcement officials and has created a new and sophisticated system for doing just that. It's an interagency effort called NYC RxStat. It will enable officials at the city, state, and federal levels to share relevant information and develop coordinated strategies to stop prescription painkiller abuse. And a number of these officials are here today, and we'll hear from them shortly. But first, let me turn things over to our health commissioner, who can describe the problem better than I, Dr. Tom Farley. Tom?
Thank you. So, as the mayor said, opioid painkiller misuse is on the rise in New York City. It's at very high levels. We estimate that there are more than 2 million prescriptions per year written in New York City. That's in a population of 8 million. So if you divide that out, that's about 1 prescription per 4 people in New York City every year. And we estimate that there are about 40,000 New Yorkers who are already dependent on these drugs and in need of drug treatment. So there is a role for these drugs in medicine, but make no mistake, these are dangerous drugs. It's best to think of them as heroin in pill form. But unlike heroin, most people get most of their pills from doctors, either directly or indirectly. We know that nearly 3/4 of people who misuse opioids get them from family and friends. That's why it's important for physicians to prescribe them only when they're needed, and only in the amount that they're needed, and only for the duration that they're needed, so that none are left over to be given to other people. Now, a year ago, the Health Department released these clinical guidelines for physicians in general on how to use these medications more carefully and more judiciously. What we're talking about today is guidelines that are specific to hospital emergency departments. These allow physicians to treat patients appropriately while discouraging inappropriate prescriptions or inappropriate amounts. So physicians can treat patients with cancer or patients at the end of life, but it will help prevent them from giving dangerous drugs to people who don't need them. Now, I want to congratulate the Health and Hospitals Corporation for adopting these guidelines across all of their 11 hospitals. Whenever there is an important public health need, the Health and Hospitals Corporation really is at the forefront in adopting that and taking a community-wide approach. And I want to encourage all New York City hospitals to look at these seriously about adopting them in their emergency departments. Now, outside of the emergency room, there are steps that every New Yorker can take to help contain this problem of prescription opioid misuse. First, keep all of your opioid prescriptions in their original labeled containers. Then keep them out of sight and out of reach of children, preferably in a locked cabinet. Don't give them to people for whom they're not prescribed. And get rid of any unneeded or unused opioid pills by flushing them down the toilet. And finally, for New Yorkers who are already dependent on opioids, treatment is available. They can call 1-800-LIFE-NET, and that number's right there on the poster. Thanks very much.
Tom, thank you. District Attorney Donovan, the District Attorney of Staten Island, is a member of our task force on prescription painkiller abuse. Staten Island, unfortunately, happens to be a borough where there is more than the rest of the city abuse of these drugs. This is a very serious problem. It is growing leaps and bounds. It is really dangerous, and we all have a part to play in making sure that we stop our kids and other adults from misusing these drugs. Dan has been on our task force and has really played a very instrumental part in moving this process along. Dan?
Thank you, Mayor, and I'd like to commend you for taking the lead in this issue. I think this is the first time that we've explored an issue like this both in the healthcare field and in law enforcement. We used to do this separately, and we've realized that this is both a health and a law enforcement issue. Staten Island happens to be a community in which every 13 days, one person in Staten Island dies from overdose of prescription drugs. We have a vast amount of people who are addicted, and I think one of the reasons why we see this with prescription drugs is this misnomer that these things are safe. They're approved by the FDA. When you take a tablet of OxyContin that says that there's 30 milligrams of oxycodone in it, somebody has actually measured that, and you can be assured of that. You buy a bag of heroin, you might be buying rat poison. These things are found in your mother's medicine cabinet, your dad's medicine cabinet, your grandparents' medicine cabinet. And most people who will secure a weapon in their home if they have a license to have a gun, or will lock their liquor cabinet, do not take care in protecting their children from prescription drugs. So we are in desperate need to fight this crime. I was in the Manhattan DA's office along with my colleague Bridget Brennan back in the 80s during the crack epidemic. We couldn't measure how much cocaine was in this country. We still can't. You can't measure how much heroin is in this country. But you can measure how much prescription drugs are, as Dr. Farley said. And we have so much information that we're now together using to combat the problem of prescription drug abuse. So again, Mr. Mayor, thank you for your leadership. I was proud to be on this committee, and I think what's most significant about this committee, besides the recommendations that the mayor is releasing today, is you'll see that the committee is not being, the task force is not being dissolved today. We continue to do our work. There's future endeavors that are described in the task force report that we plan on tackling, And I think this is something that, as Dr. Farley and I were speaking about earlier, we're going to be dealing with for many, many years from now. Thank you, Mayor.
Dan, thank you. And thank you for everything you do for Staten Island and for New York City. Also with us today is Ross Wilson. Dr. Wilson is a Senior Vice President and Chief Medical Officer of the Health and Hospitals Corporation that administers our public hospitals and clinics. And Dr. Wilson, you should also know, is overseeing implementation of these new guidelines throughout HHC. Ross?
Good afternoon, everybody. The Health and Hospital Corporation was delighted to be able to participate in the task force because we share the concern. This is a major public health problem, and it's a major public health problem caused by things that we do which are meant to be good things. We're giving medication to relieve pain, and as a result of doing that, some of that medication is diverted, misused, or abused. So our role in this is very important. As a corporation, at all of our 11 hospitals where we see more than 1 million emergency department visits a year, we have undertaken to implement all of these guidelines. We think that they make a lot of sense. We're already partway down the track. We're also introducing internal monitoring to make sure that the implementation is going successfully, and we're succeeding in reducing the number of doses of medication that we prescribe. So I would encourage all other hospitals in the city who haven't followed our lead to do that, and we open invitation to anyone else in the health system to work with us to assist us with newer ways to implement on such an important issue. Thank you very much, and it's a great opportunity to do something for a very major public health problem. Thank you.
Ross, thank you. And finally, let me introduce another task force member and an official deeply involved in stopping prescription painkiller abuse, the city's special narcotics prosecutor, Bridget Brennan. Bridget?
Thank you. Good afternoon, and thank you. Mayor Bloomberg deserves high praise for his vision in putting together this task force, which pulls together law enforcement and people from the public health field in a collaborative effort to address this epidemic. And the epidemic is causing big problems in terms of public safety, and there's no question about that. Violent crime clearly has been linked to the prescription drug epidemic, and that point was drummed home to my office when we were in the midst of an investigation into a doctor who had a pain management clinic not far away from here. And during the midst of our investigation, the terrible homicide in Medford occurred. And at that time, we were able to look at some of the data we had collected and see if any of the patients whom were seeing this doctor, who we knew were desperate addicts, had visited the pharmacy which had been robbed. And we looked at our data the day after the homicides occurred, and we were able to identify one person, David Laffer, come up with information about him, and turn the information that we had collected over to Suffolk County to assist them in their investigation. And that really drilled the point home to us, that this epidemic has great potential for violence. And it's a problem that the public health system has to address, but that law enforcement has to address as well. And this effort of putting together this task force is tremendous. The task force, because we have a mayor who doesn't just identify a problem and wring his hands about it, he put in charge two very dynamic people from his administration, Linda Gibbs and John Feinblatt, who directed us to put something concrete together. And this is the first step. The guidelines are very concrete, and they're preventive. They will help reduce demand. They will help reduce demand because they will help reduce the surplus of the opioid drugs out on the street that can be resold. And RxStat will become the CompStat for the drug epidemic, the prescription drug epidemic. It will enable us to identify trends, to show where there is really a dense amount of the drugs being prescribed. It will help us see, because it will also coordinate information about emergency room treatments and overdoses. It will help us see where those are occurring. And it will help us identify those problem prescribers. In the case that we just did, we returned an indictment for manslaughter against a doctor about 2 months ago. It took us many, many months to collect information from the ME's offices about the overdose deaths. This will expedite it. This is a great, great first step. The effort will continue for a long time. The problems of addiction are very, very difficult problems to overcome. But I believe today we've turned the corner, and I thank the mayor for that. Thank you all very much.
Bridget, thank you. When Bridget talked about getting the data from the ME's office, that's the medical examiner's office. The medical examiner is the one who looks at the deceased and decides why they had died, whether it was a crime or not, and what was the cause of death. The information now will be much more available to everyone. I should point out that Andrea Cohen is here, the Director of the Health Services for the Department of Health and Mental Hygiene, and two doctors from Elmhurst, Dr. Lewis Nelson and Dr. Stu Kessler. Doctors, thank you very much. Let me just summarize for our Spanish-speaking New Yorkers today's announcement. Tenemos nuestros guías en nuestros hospitales públicos para reducir el abuso de analgésicos recetados, un problema que ha crecido in nuestra ciudad. This is really pretty serious, and we'd be happy to take some questions. Yes, sir. Please just identify yourself.
New York Post. Does anyone know how many prescriptions HHC writes in the 2 million a year? And part two, I notice this is limited to HHC. Does the city not have the power to ask voluntary hospitals or to impose the same thing on voluntary hospitals?
Ross?
Thank you, Mr. Mayor. In our emergency departments, we write about 800,000 prescriptions for opioid painkillers each year. And we're aiming to reduce that number and also to reduce the amount of drug prescribed on each prescription.
And in terms of what powers does the health department or the city have to get other hospitals to comply with this policy?
First, I want to be clear, these are voluntary guidelines, and these are voluntary guidelines that are just being released now. So the voluntary hospitals have not had a chance yet to adopt these on a voluntary basis. But we encourage them to, and we expect that many of them will. The city does not have regulatory authority over the healthcare system, so we do not have the ability to require them to do this. We don't think that's going to be necessary, though. Our experience is that emergency room physicians welcome this as a way of providing some standard for their physician.
Well, let me also point out this is not just a New York City problem. This is a problem across this country. All of a sudden, it's really on lots of people's minds. Sir.
From WNYC. The 800,000 prescriptions from the ED, what proportion is that of the entirety of opioid prescriptions within HHC? And more globally, in general...
I think this is 800,000 out of 2 million.
Could I just clarify? It's 800,000 doses. That's a fewer number of prescriptions. The answer to the second part about the whole universe, I don't know the answer right now, but it could be obtained.
I mean, in general, is there sort of a rule of thumb, like, because much of it comes from doctors, much of it obviously comes from EDs too, but is that 1/3 is EDs and 2/3 are doctors? Is there sort of a general proportion?
I'm sorry, I'm not sure that I understand the question.
I mean, for
There are
non-EDs...
doctors in the emergency rooms who are prescribing this.
But many people get them outside of the emergency room setting, right? Is that, what proportion is emergency, what proportion is non-emergency?
We don't know the answer to that question.
There is some evidence that some doctors have abused or been very liberal and willing to write prescriptions for people that walk in and say, I want a painkiller. I want this kind of painkiller. Well, what's wrong with you? Oh, my elbow hurts. And they do it. Or people who are going to some unscrupulous doctors who say, when you ask for it, well, what hurts? Nothing. Oh, you sure? You sure? You sure? And she say, yeah, well, my shoulder hurts. Oh, okay. Yes, Miss.
Hi, Anna Mona Horticalis from the New York Times. So along those lines, though, many people who go to the emergency room, especially I would think within HHC, are going there as a primary source of medical care. So would there be any concern that they might not get the care they need because this policy would kind of...
Well, the problem is not that people aren't getting it. The problem is that people are dying because they are getting too much. What we believe is happening is that there are too many prescriptions out there. Some doctors unscrupulously just give prescriptions because people want them. But what's also a very big problem is you get a prescription, you take some of the painkiller, leave the rest, your kids take it, or you become addicted to it, taking it a lot longer than you need to have it. I don't know there's any evidence that there's anybody that believes we're not going to give enough. This is a problem of excess, not a problem of lack of. When a patient's in an emergency room, and they probably do better at HHC hospitals than any place else, the quality of the care is as good as, if not better than any place else. If they need painkillers, we give them the painkillers, but hopefully we'll be more responsible in making sure we don't overdo it. Do you want to add anything, Ross?
Just to reiterate, Mayor, that there will be no chance that patients who need pain relief will not get pain relief. What we're trying to do is to make sure that if they have an ongoing need for pain relief, they're appropriately referred to the source. So if they have a fracture, they've broken their arm or their leg, and they're going to need pain relief for longer, they're then under the care of an orthopedic surgeon who can continue pain relief for the duration that's possible. What we don't want to do is to predict that someone's going to need 20 days of pain relief for something that might just take 2 days. If they need 20 days, they need more care from somewhere else. But these guidelines will not lead to patients failing to receive pain relief that they need.
But if I can just, I think Fred's point was, do we know that the excess is coming out of emergency rooms, or maybe it's coming out of doctors' offices, as the mayor said?
At the present time, we simply do not know. But with the initiatives that are planned, we hope to get some more insights on that over the next 12 months. At the current stage, we don't know the answer to that.
And it's harder for us to find out what goes on out in the field at individual doctors' offices. We can find out what goes on in the emergency rooms, particularly in the HHC hospitals, and we certainly have a responsibility to do that. We may not save everybody's life, but any life you save is one life better. Yes, miss?
What is the city doing about those doctors that you referred to who are maybe writing more prescriptions than somebody else? Is there a way to investigate them?
Tom,
how do you handle that?
I would say most doctors are responsible and they're trying to do the right thing. They may be writing more than they should, and so that's what these guidelines are about, is to just provide them some sense of the risk and some guidance as to how to prescribe these medicines appropriately but still carefully. There are a small number of doctors out there who are maybe doing something that's truly criminal, that they're just selling prescriptions. And that's what law enforcement is about. And so we want to deal with the entire problem here with education of physicians, with this sort of guidance, as well as identification of those few physicians out there who are doing something which is really way beyond normal medical practice.
I mean, that's Dan and Bridget's job to look at when they're breaking the law, and it's hard to find. But, you know, what happens, unfortunately, is you find out after a tragedy occurs when you look back and say, why? Oh, yes.
It's not breaking the law would be selling, some sort of exchange of prescriptions.
I don't know, Bridget, you want to prosecute somebody for deliberately giving a prescription much greater than they need?
We'd look at it.
Yes, sir.
Mayor, if we could ask the Elmhurst doctors, since they're here,
Sure.
what are your experiences on this front? Do you find patients asking for more medication than they need? Do doctors generally give more than needed? And is it going to be an issue if I've had abdominal surgery and I need 4 days of medication and I only get 3?
It's a very, very complicated question. I mean, these drugs have obviously both therapeutic use, which is very important, but they also have this potential to be abused. So when patients come in and complain about pain, pain is a purely subjective complaint. You tell me how much pain you're having. It's very difficult for me to decide whether or not you have more or less pain or any pain at all, and whether you're just addicted and in need of a drug for that reason. So to answer your question as to whether or not patients are in need of more or less medication is almost an impossible task. So what we've tried to do is to say we're going to treat people's pain, especially when there's objective signs that they might have pain, and recognize that most acute pain from an ankle injury or a headache or whatever you'd like to pick lasts for 2 or 3 days. And if it lasts longer, it should be reassessed again, either in an emergency department or by a primary care doctor or by a specialist. So that's where we've come up with that 2 or 3 day requirement. There are certainly times when people have pain that we can expect is going to last much longer. And in those patients, there's really no reason why we wouldn't give more pain medication if needed. But still, I think most of those patients will need to be reassessed by somebody else after a few days anyway. So the addiction problem is very real, though. So when patients come in, it's very hard to tell whether or not they're seeking drugs for their addiction or seeking drugs for pain.
Yes.
You identify yourself, please.
I'm Dr. Lewis Nelson. I'm actually from NYU, not in Bellevue.
Okay, and just to follow up with Dr. Nelson, that was the question. How many of these pain prescriptions are being written for people you believe that are faking the pain versus have like this ankle injury? And are the new guidelines going to address that issue or just the amount of pain medication?
It's an unknowable answer. I would say that the vast majority of prescriptions that are written for people are totally valid and written for the right reasons. It's a small but real number of patients, though, who come in looking for drugs for non-medical reasons, for misuse, abuse, perhaps to sell, and for other indications. I mean, clearly, the majority of this is done for the right reasons. But the small but real number of patients who are looking for drugs for other reasons are carrying a tremendous public health burden between themselves using them, distributing them, selling them, and all of the other things that are associated with the prescription drug misuse epidemic.
And what you see is Bridget Brennan talked about the tragedy in, I think it was Medford on Long Island, where people are now holding up drugstores and killing people to get at these drugs if they can't get them from the doctors. The more times people get addicted, the more crime there's going to be, the more potential problems we have. Yes, sir?
Just following that with Dr. Nelson, I gather toothache's a very classical presentation. There are others too. I wonder if you could tell a brief vignette. The other day, a patient came in, just something that would illustrate it, and frankly, what you do on a real practical level when you suspect that this really is bogus, how you talk them out of it, how you handle it.
It's actually very difficult. So toothache is a very nice example, and most people who have toothaches have some objective sign of swelling or bad teeth, but often you can't tell. And toothache is a pretty common complaint for people who want to get drugs because you look at them and sometimes the tooth looks very normal. If you suspect they're drug seeking, and there's a lot of signs that we might look for in somebody who's drug seeking, which would include whether they've had frequent visits. We have the ability to access the prescription drug monitoring program from New York State, which will be revamped in the next couple of months, and see whether or not they've had recent prescriptions and visits to pharmacies in the past recent several weeks. We often will try to confront them if we think we have the standing to do that, but you don't want to get yourself in a position where you're doubting your patients. So when we're not sure, we're in a position to either say we won't give you any medication, in which case the patients leave unhappy, unsatisfied, perhaps in pain, or we have to give them a small prescription in order to tie them over until they can get to another healthcare provider. That is the very difficult part of practicing medicine. Pain is so subjective, we don't really know. Many physicians err on the side of just prescribing rather than not prescribing. The data we have available to us to tell if somebody's a drug seeker is very, very limited. Now, chronic pain is a little bit different as opposed to acute pain because there's usually a long legacy of findings that are associated with drug use. Patients are often upfront, and when you ask them about it, they'll tell you. And what those patients need, more than a prescription for a new drug, is referral to an addiction specialist, to a rehabilitation or detoxification program. Those are available, and we like to refer people to those. Often patients aren't willing to admit they're ready for that yet, but when they are, it's the right time to do it.
Dr. Kessler, would you like to add anything?
The only thing I would add is that, these guidelines were put together with conversations with the DOH and practicing physicians in the emergency department. So physicians talked about these a lot before they put these forward, and they worked in a way to try to do what's best for patients and still address the problems with narcotic addiction and narcotic dispensing. And I think it puts physicians in a good position, actually, because with the guidelines out there, you have something to discuss with the patient. So we can say, we have these guidelines, these are the best guidelines we have, that's why we're going to do what we're going to do. So I think it actually helps the physician and the patient in those conversations that we have to have everybody on the same, everybody kind of on the same page and understanding why we're doing what we're doing. I think it actually makes the interaction better.
Yes, miss.
Erin Jordan, Daily News. Do you have any sense of how many people who are misusing these drugs are getting them directly from a doctor versus, buying them in the black market, stealing them, etc.? And also, is there a sense of why the abuse is going up so much?
Yeah, as I said earlier, about 3/4 of people who are misusing these drugs are getting them from family and friends. Okay, so some are buying it on the street, but many of them are getting from other people. That's why it's so important not to have leftover pills in somebody's medicine cabinet so they can be given to somebody else. And I forget the second half of your question.
Just why the abuse is growing.
Well, these drugs have been promoted in the last 10, 20 years as being appropriate for chronic pain, and we feel that for most chronic pain, these are not the first choice, that people, that they are dangerous, and they've been promoted, I think, as being a little too safe. I think we're recognizing now with the increase in overdoses that they are not safe and that they're, for most cases of chronic pain, they're not appropriate. And so the doctors want to do the right thing for patients in pain. That's part of our job as doctors, to relieve pain, but we also need to be very careful about using these drugs.
Is it fair to say that it's more dangerous to give too much than too little?
It is definitely more dangerous to give too much than too little. We don't want people suffering in pain.
The young lady's question was what happens if people don't get in an emergency room, but the problem really is the other side of that is...
Right. And at one point, most people are coming to an emergency room because of an emergency, something acute, and we treat acute pain with a short course of opioids if they're appropriate. If they have a chronic problem, they need to be connected with some sort of regular physician who's monitoring their chronic problem. They may get something to tide them over until they get there, but it's really not appropriate for them to be treated in an emergency room for a chronic problem.
Yes, last question on top. Let me give this quick.
Rich Lamb, WCBS. How does an opioid addiction compare or contrast to like a heroin addiction? Is this as difficult or?
It's essentially the same addiction. It's this, these drugs have the same biologic action. If you're addicted to opioids, it's just like being addicted to heroin. It needs the same sort of treatment.
And it can get so bad your life can fall apart, and you can start committing criminal acts and hurt others, and certainly hurt your own family regardless. We'll take another couple questions off topic. Yes, sir.
Dave Seifman, New York Post. Governor proposed some casinos for upstate yesterday, but none for the city. What are your thoughts on that? Do you want to see some city casinos as well?
Well, I have always thought that casino gambling is very regressive. There's no ways you can win long term. That's the whole design of the games, that the house always wins. You may get ahead of it for a short period of time, but long term, every time you pull the lever or the wheel spins or somebody throws the craps down on the table, the average person is going to lose. And it's really just a ways to raise money. The governor's trying to do something for upstate in terms of encouraging people to go upstate and economic activity where it's sorely needed. I'm a citizen of New York State and have an obligation to support the governor and trying to help all parts of the state, so I'm sympathetic with that. But I'm not so sure that in New York City, which is the only thing I can speak, area that I can really speak of with authority, that it's appropriate. Yes, sir.
Mr. Mayor, you praised the governor's statement on guns. On the other hand, within the realm of law enforcement, he also came out very strongly against stop and frisk.
No, he didn't do that at all. He did not do that at all. He came out to support something that our administration has been supporting, and that is to change the classification of if you are stopped, stop and frisk, motor vehicle violation, whatever, if you have in your possession and show it narcotics, how that is treated. It goes from a misdemeanor to a... From misdemeanor to a violation. From a misdemeanor to a violation. That's the only thing he talked about. And our administration has been supporting that for a long time.
Saying that too many people are being stopped, too many of them are young, and too many of them are of color.
I think what he... Well, he did... Huh? I don't believe he said that, number one. Number two, I think the statistics clearly show we stop people where there is crime. There is an enormously high correlation. We go right where the problem places are, and that it has been a phenomenally successful program in terms of reducing the number of guns on our streets. If you're not happy with 418 murders in this city compared to the murder rate in any other city, I don't know how we could even have a conversation. If you lived in Detroit and had this murder rate, you'd have 4,400 murders. I think the other 4,000 families might want to have a conversation with you. Yes, sir.
Jason Kessler, CNN. Question about gun control. What advice do you give mayors like Mayor Nutter of Philadelphia, who are pushing for stricter gun regulations in their cities, but they may be trumped at the state level?
Mayor Nutter, who happens to be one of the bright up-and-coming mayors in this country, campaigned on bringing in an aggressive program of stop and frisk to convince the kids that if they carried a gun, they're likely to get stopped, they're likely to get arrested. And he brought the murder rate down precipitously in Philadelphia almost overnight. He then got stopped from doing it by some misguided judgments, and the murder rate went right back up. Mayor Nutter, unfortunately, has to go to some of these funerals and try to explain why the loved ones who wouldn't have gotten killed have gotten killed. And it's something that everybody that's opposed to this would be interesting to see if they have the courage to come with me and explain to the police officer who got killed, to their spouse or their child or their parents, that it was a murder we could have stopped and we didn't have the courage to do. Mayor Nutter has to stand up, and he's going to fight as hard as anybody can. In many of these cases, there are conflicting views and conflicting, for example, in the case where a judge ruled yesterday that the police cannot do what they've been doing in terms of being invited into a private building and patrolling the stairs. The tenants in those buildings overwhelmingly want those cops there. It is somebody outside of who lives in a building with a doorman where they don't have the problems that is thinking, oh, isn't this terrible? No, it's terrible. You lose a life, you'll never get it back. Any other questions? Yes, behind you, Miss.
Mayor, I was hoping you could talk about the flu outbreak that people are seeing nationally. What's happening here in New York City in terms of the flu, and for some of the doctors that are here, if you could tell us what you're seeing in your hospital.
Well, why don't I let Tom Farley do it, although I will say I probably had the flu a few weeks ago, so maybe I don't know. I had a cold. It was bad cold. Maybe it's not the flu. I don't know. And I did get a flu shot. But flu shots, remember the way flu shots work, the pharmaceutical companies have to decide a year or so in advance what the next strain of flu is going to be. Sometimes they get it right, sometimes they don't. And sometimes there's multiple strains out there. Tom?
As you know, we have a flu epidemic every year, and we're having our flu epidemic now, and it's a bad year. We got lots of flu. It's mainly type A H3N2, which tends to be a little more severe. So we're seeing plenty of cases of flu and plenty of people sick with flu. Plenty of hospital emergency departments are seeing many patients, and so they tend to be crowded. Our message for main people who are listening to this is it's still not too late to get your flu shot. If you haven't gotten the flu yet, and if you haven't gotten your flu shot yet, you can still get it. Despite what the mayor said, most people are going to be protected. Not everyone is going to be protected from a flu shot. Or if it doesn't totally protect you, what it does is it makes the illness milder, and that's important. Okay, you'd rather be feeling a little lousy for a couple days than getting deathly ill for a week, and it can have that benefit as well. So if you haven't had your flu shot yet, get it now. If you are sick with the flu and you don't absolutely need to go to a hospital emergency department, don't go because it's too crowded, and for the most part, you're going to get okay. You're going to get well on your own, so just stay at home or go to your regular doctor.
Also, the likelihood of you catching something in an emergency room is much greater than if you stay at home. All the advice is if you don't need to go to an emergency room, don't go. Miss, we'll take the last question.
I just wondered if there are more cases of flu this year than last year.
Tom?
And also, Mayor Menino in Boston had yesterday declared a public health emergency, and I'm wondering if you're thinking of doing anything
We
like
are
that.
going to listen to Tom.
Yeah, the way that we can't count individual flu cases, but the way that we measure this is what percent of the emergency department visits are for somebody who looks like they have flu. And right now we're above 5%. Typically during a non-flu time we'll be below 2%. So that's a very high level. That's higher than we've seen in other years. So we know we have more flu than we would have during non-flu seasons and more flu than in other seasons. We don't see any need to declare a public health emergency. We want to get our message out that if you haven't had your flu shot yet and you haven't been sick, time to get it now.
And if you have it and you're not really dying, don't go to the hospital.
Are you advising people to, besides getting a flu shot, is there anything you're advising people to do, like, wash your hands or anything like that?
People should wash their hands. People should cover their cough. But I want to emphasize the flu shot because that's the best way to protect yourself.
And could you just talk a little bit more about the 5%? Is it's 5% of all hospital emergency visits, or explain it a little bit more?
Yeah, we get data every day from almost every hospital emergency department in the city, and we look through the text of what doctors there write and see if this is describing a patient who looks like they might have influenza. We call it influenza-like illness. So that's of all the emergency department visits in the city, a little more than 5% right now are due to influenza-like illness. That's our measure of how high we are in the flu epidemic each year.
And let me just finish by saying I took my flu shot. I don't know if I had the flu. I don't know that it would have been a lot worse, but I'm glad I took the flu shot. I've always taken a flu shot, and I plan to take a flu shot next year. And anybody that doesn't, I think, is just missing an opportunity to protect themselves. There's no guarantees in life. You can take your flu shot and then walk across the street, and if you don't look both ways, get hit by a car. That doesn't mean you shouldn't take your flu shot. And opioids is a very serious problem. This is a national problem. We start to see it more and more in New York City, which is our responsibility. But unfortunately, people are not understanding that drugs are dangerous. They are designed to be used in moderation when prescribed by a doctor and even when they're over the counter, not in excess. And if doctors get the message, they will help. If people who take painkillers, make sure they don't let them fall in the hands of their children or other family members. If pharmacies, make sure they watch very carefully, because the likelihood, the more this addiction takes place, the more likely it is that pharmacies are going to be held up or people going to get robbed when they walk out of pharmacies. This is a serious thing. Thank you very much.
Great job.
Grab passages, we can compare notes.